Yes, good to go. Oh, good morning, everybody, and welcome. Can we move to the next slide, please? The actual first content slide. So hello, everyone. I'm Sharon Eloranta. I am the Medical Director for Performance Measurement and Practice Transformation at the Washington Health Alliance. Welcome to today's presentation, Colorectal Cancer, third leading cause of cancer death in Washington. So screen it like you mean it. This presentation is brought to you by the Washington Health Alliance in partnership with Exact Sciences. Next slide, please. Couple housekeeping items. Mute is currently activated for all but presenters. We want to hear your questions though, so please enter them throughout the entire presentation into the Q&A, not the chat, but the Q&A. And we will do our best to answer them all. We may even use some of them in the panel presentation. That'll be exciting. And if we do not have time to get to your question, we will be sending responses by email as quickly as we possibly can. And yes, all registrants will receive the presentation deck and the session recording. Next slide, please. So the Washington Health Alliance, although you probably know us pretty well, we are a multi-stakeholder organization whose mission is to prepare and challenge our membership organizations to identify and choose actions that will improve healthcare value through improving clinical quality, driving affordable cost trends, and optimizing health outcomes across all communities. We give thanks to all of our members who are joining us today, and if we have any non-members in the audience, we encourage you to consider joining us. Next, please. Examples of some things that will be coming up next for our members in 2024. If you need a little incentive to join or join us on those, we will be hosting webinars on topics including but not limited to those listed here: substance use disorder, women's health with a focus on menopause and its impact on and within the workplace, weight-related conditions, affording and affordability of cell and gene therapies, and we will be talking about a new release of our Do No Harm, the Health Waste Calculator report, this time with a social driver of health focus. Also, members can attend and become members of our committees. We have a quality improvement committee, health economics, consumer engagement, purchaser affinity group, and we will be holding member-only convenings and initiatives related to issues such as hospital price transparency, health equity, and support for primary care. Next, please. So this is what we're going to be doing over the next little bit. We will learn about the problem of colorectal cancer and barriers to screening and care. We will also learn about costs associated with screening and the impact of costs of not screening. And then we'll hear about a successful initiative to increase screening rates at Virginia Mason Franciscan Health, followed by a panel discussion. Next. Next slide, please. So just to give a little background, and we'll get a lot more data in just a moment, the current state of colorectal cancer screening in Washington, as calculated by the Washington Health Alliance's voluntary all-payer claims database, indicates that our Washington average rate of screening is 61%. So just over half of the individuals that USPSTF says should be screened are being screened in our state. That's kind of sad. And as related to the national benchmark, that is 72%, which isn't super either, but we're below that. And in fact, as you can see those little series of ovals down there on the slide, that depicts the percent of the measures that we report on that fall in which percentiles compared nationally. Our colorectal cancer screening rate is in that little yellow oval, which means it is between the 25th and 50th percentile rate nationally at 61%. So we clearly have room for improvement. Let us go to the next. So while we all listen to our experts speak here in a moment, I want everyone to keep kind of thinking, what can you do in your role as an employer, a health plan, provider, allied organization? And I believe it's true that all stakeholders can help increase colorectal cancer screening rates, as we will learn from our experts. And we'll also hear a lot of good information about various types of screening, and you'll kind of maybe expand your knowledge of those. From my personal viewpoint, and this is my only opinion piece I'm going to give you, the best screening test is the one that gets done. So let's get everybody screened. Next slide, please. This is my little bit longer talk, but this is our effort here at the Washington Health Alliance to put an equity lens on everything that we do. So this is our representation of our current colorectal cancer screening rates as associated with social drivers of health. So to look at social drivers of health, we utilize the Area Deprivation Index, which is a publicly available free of charge program that is operated by the University of Wisconsin. The Area Deprivation Index comprises 17 indicators of socioeconomic challenge, such as percent of families living in a certain area below the poverty level, percent of families living in a certain area that are single parent families, and so forth. It has no health information in it, nothing about health conditions or health risk factors. It also does not contain race or ethnicity. So this is purely socioeconomic indicators that are within this. So what you are looking at here are the colorectal cancer screening rates arranged across the deciles as calculated in the Area Deprivation Index. So the Area Deprivation Index, you can see on the bottom of the graph, there's a little line that says 1 through 10, takes census blocks and uses those indicators to assign a decile of greater or lesser socioeconomic deprivation. In the way they do it, lower numbers mean less deprivation and higher deciles would be more. The lines in this graph, the blue line depicts the performance for the colorectal cancer screening measure for people with commercial insurance, and the yellow or orange line depicts those with Medicaid insurance. You can instantly see that there's an inequity here by insurance type, because across all of the deciles, the Medicaid screening rate lags behind the commercially insured. But you can see that for both, in areas with less socioeconomic challenge, the screening rates are higher and tail off significantly as we approach areas that people live in with more socioeconomic challenge. So we clearly have an inequity here based on social drivers of health. And we're going to need to address this screening disadvantage in order to reduce unnecessary disease and death. Next one, and I'm almost done yakking. We have our first poll. So I'm going to call on Nick to operate our participant poll. We are inviting you to enter your best guess. We're going to do a little test of your knowledge before we tell you the answers. Which of the following racial or ethnic groups of people has the highest incidence of colorectal cancer? So this is incidence. And you see the choices there, and we'll just see how well you do. Nick, let me know when you feel like most people have answered, if we're going to see the answers or not on the screen.
Sharon, you can move forward because Catherine will address this during her presentation.
Okay, so let's go on to the next slide while we continue to fill this out. Here's some introductions for our speakers. Very excited to have these experts with us today. First, we will be hearing from Catherine Kushedji. She is the Medical Science Liaison for Exact Sciences, followed by Wendy Bebo, who is the Field Director for Health Economics and Outcomes Research, also with Exact Sciences, and Colin Walker, Division Director for Ambulatory Quality and Population Health with Virginia Mason Franciscan Health. Catherine, you can take it away. The floor is yours. And next slide, please, for Catherine.
Okay, thank you very much, Dr. Eloranta. I want to, first of all, say thank you to the Washington Health Alliance. They have been amazing partners to work with, and I want to congratulate Dr. Eloranta for pronouncing my name 100% correctly. So it's a challenging name. So we're going to talk a little bit about screening and detection in Washington State. So next slide. So there is nationally an organization called the United States Preventive Services Task Force, and this is guideline of recommendations that surrounds colon cancer screening. And it also includes the American Cancer Society, the American College of Gastroenterology, and the Multi-Society Task Force. And it illustrates the age to begin screening, continue screening until age, and then screening after 75. Up to 2 years ago, screening was indicated for individuals between the age of 50 and 75. But because people are living longer, it is up to the individual and the provider to screen past 75. And because we were seeing so many other cases below the age of 50, the recommendation now is to begin screening at age 45. And we are also seeing an uptick in colorectal cancer in those individuals under the age of 45. So we anticipate that will also change soon. Next slide, please. Colorectal cancer, or CRC, as Dr. Eloranta said, is very preventable. There was a study done between 2006 and 2012 in Northern and Southern California amongst the Kaiser system. And of all the patients that died of colorectal cancer, 76% were not up to date on their screening. So if you imagine all those patients, if they had been up to date on their screening, the lives that could have been saved. Next slide, please. Many challenges exist in cancer. This year alone, there'll be nearly 2 million new cancer cases diagnosed. There'll be 600,000 cancer deaths. But more importantly, disparities still exist and are present in cancer. And we're going to talk about those in a minute. Next slide, please. Colorectal cancer, the incidence or the number of people that are diagnosed with it varies amongst all populations. So it is the third most common type of newly diagnosed cancers in both men and women in the United States. This year alone, there'll be over 153 new cases of CRC. But it does vary by your race and ethnicity. American Indians and Alaska Native people and Black individuals have the highest diagnoses of CRC. In fact, Alaska Natives have the highest incidence rates in the world. So next slide, please. So if we compare that to not only the number of cases that are diagnosed, the incident, but we look at the mortality of those individuals that have diagnosis and then have death from that diagnosis, that also varies across populations. Unfortunately, we are seeing that same trend, that those individuals that fall in the category of Alaska Native, American Indian, and Black individuals have the highest rate of mortality from a CRC diagnosis. And these are caused by socioeconomic characteristics and social determinants of health. And we'll talk about that in a minute. Thank you. Next slide. Early detection is absolutely critical. If you take nothing away from this, remember this slide. If we can catch colorectal cancer in stage 1 or stage 2, the individual has a 91% chance of a 5-year survivability. And after 5 years, people go back into the general population. If we get it where it's the regional state, where it's gone outside of the colon, they have at stage 2C or stage 3, they will have a 73% chance of a 5-year survivability rate. If we don't get it until stage 4, where it has metastasized throughout the body, that survivability rate goes down to 14%. What's important about this is that individuals oftentimes do not experience any symptoms until they are at stage 4. So that is why screening is so critical. And screening must be done on a regular schedule, because we don't want to get individuals at stage 4. We want to get them early when it's most treatable. Next slide, please. Washington State, as Dr. Eloranta said, has a average screening rate, but it's not great. Many different organizations will rate it, but it's right around that 50 plus percentage. And that's for the state in totality. So we're going to look at another screen in a minute that will kind of include those social determinants of health, but we need to get it higher. There are lives that are being lost. Next slide, please. The CRC numbers are climbing annually. These two graphs illustrate that the one on the left is the climb in those individuals aged 20 to 49 years. And the rate of CRC diagnosis is climbing by 2 to 3% a year in this population. The reasoning they are thinking this is because there was a large birth cohort during this time in this population. Also, this population were the first ones exposed to social media and to cell phones. And there was a decrease in activity, increase in processed foods. And so those are some of the contributing factors along with the regular ones. So that population, CRC, is rising, and we are seeing cases of individuals in their 20s being diagnosed. On the right, the slide is showing that those individuals aged 50 to 75, the rates are declining. And the reasoning for that is that they are doing their screenings. They are getting the information to do their screenings, and they're taking it seriously. So next slide. So again, let's look at the data from those individuals that are maybe underinsured or non-insured. And in Washington State, again, the total population was above 50% for screening. But if you look at the individuals who are served by federally qualified health centers, and this study just looked at those individuals aged 50 to 74 years before the recommendations changed, only 42 or less than half of that isolated population is screened. So we definitely need to change that. And those are individuals that may reside in rural communities. Next slide, please. There's many barriers to screening. Patients were interviewed and surveys were taken. In the awareness category, a lot of patients don't even know about it. They don't know that there's a value for it. They don't get to see that chart of stage 1 through stage 4. They just hear like, oh, I'm 45 or 50, I should get screened. They don't hear it from their providers necessarily. Providers are tasked with seeing a ton of patients in a day, and they come in with a variety of problems, some of them very challenging, and to try to get in all the things they need to say to their patients is nearly impossible. So screening may be way on the back burner. They may have a fear of pain or discomfort. They may have a fear of worrying about getting the results. So if I don't take the screening, I don't have to find out the results. And it may be a low priority. A lot of these screenings require that you take time off from work or get rides or other issues that impede daily living. And then there's the socioeconomic components. Again, lack of transportation. Not everyone has a car. And in some communities, even if you live 15 miles away from a center that could screen you, there is no transportation. Costs due to lack of income or insurance, discrimination by age, or disability, or race, or income, and low literacy. And it's not just language barriers, it may be educational levels. So next slide, please. At this slide, I find really interesting because it's not just barriers to patients. This study was done to look at what are barriers to providers and what are barriers to organizations. So we looked at patient level barriers, and again, there was fear and finances, other comorbidities or health issues, lack of awareness and health literacy. And but for providers, they are really expressing they don't have the time to discuss screening. They don't have the time to give recommendations, and they don't know enough about the efficacy of all the different screening products. So it's not easy for product companies to get into physician or provider offices anymore. So there's a lot of misinformation out there, and it's our job as healthcare individuals to really educate. And then from a system level or an organizational level, there may not be a reminder or support staff to recommend to the providers. You need to really get after people to get their screening done. And there is a shortage of screening facilities. And COVID really not only put us kind of on the backlog for getting screening done, but there also is a shortage of providers. So we need to look at other modalities. Next slide, please. So if we look at other modalities and we look at adherence, or do people actually get them done, there are, several modalities. There is the traditional colonoscopy, or there is fecal occult blood testing, which basically there's two tests right now. One is called FIT, and the other one is uh, multi-targeted stool DNA. You may know it as Cologuard. And they both look for hemoglobin or blood in the stool. What this study looks at is it looks at two arms. So it looks at patients who were just given the option to do the FOBT or the stool-based testing, and then one arm that looked at patients who were only given the option to do colonoscopy. So if you look at those two, the stool testing actually was a little bit higher. But if you give patients the choice, if you have shared decision making between providers and patients, the number goes way up. Patients feel empowered. They feel that they can make the best decision for themselves and for their support people. So next slide, please. So let's look at the performance of non-invasive or these stool-based tests. So sensitivity is another word for how well does these tests pick up potential cancer for CRC. So the stool-based tests, again, are the FIT tests, which looks at if there is blood in the stool or not, or the multi-targeted stool DNA, which looks at if there is not only blood in the stool, but also looks at 11 different biomarkers that are DNA-based that will give us indications of if there is cancer cells available. So if we look at the staging of the two tests, we can see that for stage 1 and 2, the multi-targeted stool DNA is superior to the FIT test. For stage 3, they're about equal. For stage 4, they're about equal. But for beginning stage 4, but overall, the multi-targeted stool DNA outweighs the FIT testing. And then if we look at the advanced precancerous lesions, according to location, multi-targeted stool DNA is able to get more identifying lesions throughout the colon. So not just at the beginning of the colon, the proximal part, but also the distant part, where it's much more dangerous. So if you'd like to go to the next slide. So someone takes a non-invasive test, one of these stool-based tests, and they are given the results that they have a positive result. They have blood in their stool, and then if they do the multi-targeted stool DNA one, they have these markers that indicate they may have colorectal cancer. It is recommended, strongly recommended by both of these tests that they do a follow-up colonoscopy. And that is for the doctors to take a really good look to see where the cancer is and where the polyps are, and to make sure there is something there or there isn't something there. So this survey looked at, do patients adhere to doing full follow-up colonoscopies? And from the patient level, patients definitely did more follow-up with the multi-targeted stool DNA. And upon survey, it appeared that they had a little more belief in the biomarkers. So it gave them a little bit more substance. From the provider level, it was kind of mixed. They believed that the adherence was kind of 50-50. But from the system level, they also believed that adherence could be one way or the other. So, but it was very clear from the patient perspective that they preferred the multi-targeted stool DNA and that they adhered more frequently by using that. Next slide, please. So in summary for my section, I'd like to remind you that CRC is the third most common cancer, second leading cause of cancer deaths, highly preventable, highly treated if we get it early. The national guidelines recommend screening between 45 and 75. Fear, finances, logistics are barriers to screening. Informed decision-making or having that shared discussion and test choices improve screening adherence. And before Wendy gets started, she has a really great session too. I'd like to encourage any of you that would like to partner with with either of us to get more information to go ahead and reach out. But thank you very much. And Wendy, take it away.
Great. Thank you so much, Catherine. And apologies if my video goes out. I've been having trouble with internet connectivity. So please let me know if my audio goes out or anything else, any type of technical difficulties. But as Catherine mentioned, I'll be providing a brief overview of the economic consequences of caring for CRC and how it may impact productivity. Next slide, please. I know we've reviewed some of these national statistics already, but just as a reminder, from a national perspective, CRC is the third most common cancer, but the second most common cause of cancer deaths. So now let me try to shift your thinking. When you hear about cancer, what are the issues that come to mind? And while we understand that there have been amazing advances made in cancer care, but with that, it may be even more natural to think and worry about the associated costs. Unfortunately, cancers are not cheap to treat, and the costs associated with treating CRC are quite high, where in total, the estimated cost of CRC care was around $18.2 billion, and this is in 2021 dollars. The NCI has a slightly higher estimate in 2020 dollars, where the total cost of CRC care was around $24 billion, representing the second highest cost associated with treating any cancer. So the range of total spend in the US on CRC care ranges from 18 to 24 billion. To put that into perspective, that represents around 11% of the spend for all cancers combined. So I'm a numbers person, and forgive me for providing all these estimates, but let me put some of these estimates into perspective from a state level. The CDC estimated that Washington state spend on all cancers in 2020 was a little over $6 billion. So this $6 billion that Washington state spent on all cancers represent around 3% of what all states combined spent on cancer care. To further estimate what Washington spent on CRC care, I'm applying the proportion of CRC spend to all cancers, which is about 11%. So 11% of $6 billion is around $660 million, meaning it is estimated that Washington spent around $660 million on cancer care. And something else to consider, that these cost of care estimates do not necessarily take into account loss of productivity. And the national estimate is calculated to be nearly $36 billion. So the bottom line here is that these costs impose a substantial burden on state budgets. Next slide, please. So before I keep overwhelming you with economic estimates relating to CRC care, Catherine provided some really nice statistics on incidence rates. So I just want to quickly provide some additional incidence rates specific to Washington states. So one of the differences we see is the prevalence of CRC within Washington, and that's lower than the national rate. So just as a reminder, CRC nationally is the third most common cancer and the second most common cause of cancer deaths. Whereas within Washington, CRC is the sixth most common cancer and the third most common cause of cancer deaths. Drilling down further with incidence and mortality tables on the left, you'll see that Washington has slightly lower incidence and death rates compared to national rates. Moving to the bar graph to the right of that, there's a breakdown of stage at diagnosis, where a majority of CRC cases are diagnosed at either a locally or regional stage. And then in the far right table, there are national 5-year survival rates that correspond with stage of diagnosis. And the obvious bottom line here is in what Catherine has said, is that CRC is quite a serious cancer, both nationally and statewide. And to reiterate our common theme, and that's diagnosing CRC earlier in the disease course rather than later can not only save lives, but also may alleviate financial burden. Next slide, please. So transitioning gears to focus back out on costs associated with CRC care. This slide emphasizes two key take-home messages relating to survival rates and associated costs with treating patients with each respective stage. And if you can fast forward through all of, thank you. So the first take-home message here is that, as we've mentioned before, the earlier stage CRC is diagnosed, the higher the survival rate. So nothing surprising with that trend, and that's fairly seen across all tumor types. The second take-home message is that, and again, nothing new with this trend, but the earlier in the disease course CRC is diagnosed, the lower the associated costs. So let me direct your attention to focus on the right side of the slide, where survival rates and the corresponding cost estimates. So if you look at a patient who is diagnosed at stage 4, not only does their survival rate plummet, but the cost associated with treating patients in stage 4 precipitously increases. And again, to sound like a broken record, earlier detection may be key in saving lives, but also adding less economic strain on state budgets. So based on this understanding, I think it begs the question, how much economic savings can screening strategies actually provide? Next slide, please. And so magically enough to answer that question, one more to go to the next slide. Thank you. So just to answer that question, this slide shows results from a few modeling studies that were published that help us understand overall, any screening strategy is better than none. And what do I mean by that? So the bar graphs below show modeling estimates that indicate cost savings regardless of the non-invasive screening modality across Medicare and Medicaid patients. Focusing to the graph on the left, which relates to a Medicare model, the potential cost savings over the course of a lifetime range from $600 million to $1.2 billion, so not an insignificant savings. There was another study published that conducted a similar model, but applying it to a Medicaid population, and the potential cost savings over the course of a lifetime range from $400 million to $800 million. So again, the point of this slide is not to compare screening modalities, but to provide evidence and estimates of how much any screening strategy versus no screening strategy can help save states money. Next slide, please. So we're progressing to impact on productivity, and then you can go to the next slide. So just on the other end of the spectrum of savings and spending, there's another element of the cost consequences of living with CRC, and it relates to jobs, specifically the consequences of not being able to work, such as absenteeism and the cost to support disability claims. So if you look at the box on the left side, there's evidence that people living with CRC have much higher work-related costs versus people without CRC. The bar graph to the right quantifies or translates the cost when people miss work and the costs associated with short-term disability. So in the lower part, you can see that the costs related to short-term disability for people with CRC versus people without CRC are slightly more than 6-fold. So the obvious interpretation is that there are substantial cost consequences associated with the inability to work due to living with CRC. So just to summarize this portion, we just understand that the total cost of care for a person living with CRC is substantial, especially when you consider treatment and work-related costs. We also understand that costs increase the later in stage CRC is diagnosed. Therefore, earlier detection or earlier screening strategies become key in detecting CRC earlier rather than later, as this will help aid improve overall survival rates and the costs associated with CRC care. So thank you very much for your attention. And now I'll pass it on over to Colin, who will no doubt dazzle you with their efforts at increasing screening rates.
Yeah, thank you very much. My name is Colin Walker. I'm the Division Director for Ambulatory Quality and Population Health for Virginia Mason Franciscan Health. Really appreciate the opportunity to be here and talk a little bit about our journey at VMFH around colorectal cancer screening. So just to provide some brief context, this is kind of a snapshot of our facilities within the Puget Sound region at VMFH. We have 11 overall hospitals, one of which is a behavioral health hospital and one of which is a rehab hospital. And then close to 300 ambulatory care sites, about 40 of which are primary care. So we work a lot with our primary care partners across the region. Next slide, please. So just to give you some context on kind of how quality improvement is structured at Virginia Mason Franciscan Health, we use a variety of different kind of methodologies and programs, predominantly a process improvement system called the Virginia Mason Production System, which is based on lean management principles, and the Toyota Production System, and really enforcing a strategy of plan, do, study, act, and making sure we've got kind of organizational prioritization and will and execution combined to create overall structure for process improvement and quality improvement. But it really breaks down to kind of into three buckets for us in terms of quality improvement and pop health. One being structure, so creating committees, governance structures, champs, best practice guiding teams that kind of create the work system. So focusing a lot of our system level enhancement. So for CRC screening, looking at less clicks and ordering, automation within the EHRs, et cetera. And then process enhancements, really focusing kind of at the patient or provider level. What can we do to enhance kind of CRC screening at the process level? So kind of combine those three things. Next slide, please. Into an overall kind of organizational approach. And so we are lucky enough to have a centralized team called the Ambulatory Quality and Population Health Department. It's a small but mighty group that really kind of takes that approach that I just mentioned and formulates it into kind of these key areas of focus. One being on custom analytics, so having the data available to drive change and monitor change. One being on education and engagement with clinicians and clinic teams. To really help enforce why we're doing what we're doing and what we're trying to focus on. Really focusing on system level improvement and innovation, trying to look for easier and better ways of doing things, which I'll talk more about. And then another kind of group or focus of work for us is value-based. So all of the vast majority of our contracts with different payers and value-based performance have colorectal cancer screening as one of those measures. So this is kind of our overall ambulatory quality and pop health approach at the organization. I just want to provide a little bit of context to how do we structuralize the activities that I'm going to talk about in a second. Next slide, please. So as mentioned, colorectal cancer screening is an incredibly important aspect of overall cancer screenings. We try to structure our kind of prioritizations in terms of lives saved. Heart disease being the #1 cause of death in the United States, but cancer is #2. So a lot of our kind of overall focus from a prioritization standpoint as an organization is kind of built in this framework. Next slide, please. We've kind of created a hierarchy of needs, of quality needs. So annual wellness visits, overall prevention activities, chronic disease management with diabetes management, hypertension management, transitional care management and prevention of hospital readmissions, and the cancer screenings are kind of the base priorities we have from kind of a systems perspective. Next slide, please. So a little bit of our journey in colorectal cancer improvement really started in earnest in 2018, previous to my time within the department. But at that time, we really kind of defined, okay, what are we trying to accomplish? And at the time, it was really gearing towards the community efforts of getting to 80% of colorectal cancer screenings within our communities. Looked at why does this change need to happen? Quantifying the opportunity. So as mentioned and has been mentioned in the previous presentations, we really look at lives saved, but also cost savings, bed days diverted, etc. And one kind of interesting statistic is for every 1,000 patients that you screen, you save roughly 3 lives. And so really kind of focusing on that as to the why. And then looking at how do we measure our improvement? How do we know there's improvement? So we defined organizational objectives and targets, defined the current processes and opportunities, identified system and structural opportunities, and find the ways to kind of measure the improvement. So a lot of planning and pre-effort went into kind of this overall journey of improving our colorectal cancer screening. Next slide, please. So here's a snapshot of kind of all the activities. There was literally probably hundreds of different activities that went in over the last number of years into kind of improving our CRC screening rates. But the big groups were really about identifying patients due for colorectal cancer screening, so making sure we had gap lists, that providers and clinic teams, especially in primary care, were huddling daily to kind of review those gap lists. And I'll talk about all the things that have stars on them in more detail, but just this is kind of an overall snapshot of the work. Making sure we had outreach opportunities, so both clinic level outreach, but also centralized outreach to large groups of our patient population. Looking at the opportunities within the EHR system to enhance, make it easier, more automation. One of the things that we've done is build a bidirectional interface with Cologuard so that we can order fit DNAs and receive fit DNA results directly in the EHR. Making sure we focus on patient and staff education, creating those discussion guides with patients in mind that have hesitation about colonoscopy, et cetera, and what options are there for them. Access is a key component. We created a centralized hotline to schedule colonoscopies that any patient can call, for example. So really looking at that as an opportunity. And then, as I mentioned, overall system improvement, kind of continue looking at ways to improve all of our opportunities from a systems perspective. Next slide, please. So this is kind of just taking some of the buckets I just described and going into more detail. One of the first things we did was create some visualization, some data visualization. So we utilize what we call a provider scorecard. So this is a balanced scorecard approach. It's a little difficult to see on this slide, but when you get the slide deck, you can see it more specifics. But we have 17 major ambulatory quality metrics that we focus on, colorectal cancer screenings being one of them. So defining a metric and having that visible. We use HEDIS specifications for the build of that metric. These scorecards are available at the clinic, region, and provider level. They're available daily. They get published via email and sent monthly. And these are outcome-based and performance-based. So what's our current rate of colorectal cancer screening for the defined population, whether that's at the clinic level, the provider level, or the region level. We also built process metrics, and process metrics are more how often is a standard process being followed. So in colorectal cancer situation, how often does a patient come in? They're due for their CRC screening, and actually order it while they're during the visit. And how much are we hearing kind of that standard best practice? And then tracking and trending this data over time has been really valuable, showing those where interventions have happened and where improvements happened. Next slide, please. Thank you. Another key aspect that I briefly described is just kind of this provider and patient education component. So for pretty much every major initiative and metric that we have, we develop a toolkit that's really geared towards providers and clinic teams. You know, the why behind why it's important. Additional resources and tools are out there. Screenshots of the process flows within the EHRs. How to order colonoscopy, how to order fit DNA, how to order FOBT, et cetera. Really kind of laying it out as a process flow for the clinicians and the teams on how to do the work. Patient education is crucial as well, trying to promote as much as we can on the website, utilizing colorectal cancer awareness month, doing social campaigns has been something we focused a lot on. And then, as I mentioned, creating a centralized system for scheduling and try to ease that process as much as possible. Next slide, please. Another kind of highlight is kind of gap list visibility, making it really clear on who's due and for what screening modality. So we create something called the Tomorrow Report that gets sent to all of our primary care teams daily, and it says who's on their schedule for the next day and what they're due for. So it mirrors health maintenance in the EHR, where it's kind of really clear, hey, you've got this patient coming in, they're due for their CRC screening, go ahead and huddle around that and get it ordered. Creating centralized outreach wherever possible. Ideally, patient or providers and teams calling from the clinic has kind of the highest utilization of action. So we try to combine that with centralized outreach, because a lot of the clinics don't have a lot of capacity for direct outreach, but trying to make it as simple as possible by creating smart phrases, scripting, standard approaches to making that outreach is something we focused a lot on. Next slide, please. What we call robotic automated processes, and try to systems innovation overall has been really crucial. RPAs are kind of artificial intelligence built into the AHR, where it'll scan for a patient that's due for particular cancer screening, in this case colorectal cancer screening, and it'll actually pen the order for what they're due for, so colonoscopy or fit DNA, etc., on the day of the visit. So basically, when a patient's scheduled and they're coming in, the provider automatically gets an alert that basically has a pended order for, say, a fit DNA. They can go ahead and click that, approve the order, and it's kind of a seamless process. So looking for ways to automate as much as possible within the EHR has been really helpful. And then we do try to create some kind of fun initiatives and programs. We do what's called a colorectal cancer screening challenge, which we're actually in the midst of right now, where we take all the primary care clinics and give them data, kind of what their performance is, what's the number of patients due for CRC screening that they have at their clinic, and create a little competition around it. So it's fun. It's just a different way of approaching the work. We create, the winners get like lunch at their clinic. We try to give weekly updates. We run the challenge between 4 and 8 weeks. Just kind of giving overall reminders on why this is important work and creating some kind of fun initiatives around it. Next slide, please. So that's kind of just highlights of the major activities, but wanted to also mention that, a key focus area for us has been around preventative wellness visits, in particular the Medicare annual wellness visit. When you see patients kind of compare those without an AWV and those with an AWV, you see about a 10% increase in their colorectal cancer screening rates. So really having initiatives and focus areas on AWVs has been very helpful for us. There's a direct correlation between AWVs completed and colonoscopies completed, as you can see on the right-hand slide there. And then there's overall financial incentives to getting AWVs done as well. So I just want to mention that as a key area of opportunity. Next slide, please. And as I mentioned at the beginning, trying to represent everything in lives saved as much as possible. So out of, this is data from a few years ago, but out of 12,000 additional colorectal cancer screenings done, we save 43 lives, right? And so translating that data into actual kind of actionable items for our clinicians has been really helpful, saying that we're saving lives and allowing people to spend more time with their families, etc. Next slide, please. So here's just a snapshot of kind of the journey for us. If you actually look prior to 2019, it was actually a lower colorectal cancer screening rate. This is for Franciscan Medical Group, which is kind of 60% of the overall primary care clinics we have at the organization. And really have kind of has this increase over time and all the activities. So having this data available, showing where the initiatives happen, to continue to gain organizational support and buy-in has been really helpful. I'm just kind of share this insight of kind of creating this data visibility and helping share our journey. Next slide, please. And then just finally, we've been really honored to have gotten some recognition for this important work. Most recently with being one of 5 organizations recognized nationally by the National Colorectal Cancer Roundtable for our work in 2023 on colorectal cancer screening. and great partners in the American Cancer Society and others in kind of forwarding this work. Final slide, please. So overall, kind of key lessons for us and learnings: automate wherever possible, utilize kind of process opportunities to identify improvements, utilize quality improvement models, and it's really important to get those that are doing the work involved in the improvement of the work. They know it best. Leadership alignment and coalitions are crucial. Creating opportunities to share best practice. There's a lot of, in the primary care world, lots of primary care clinics that are doing things differently and interestingly, and having the opportunity to share that across the system has been really helpful for us. Making data visual, making competition, a little competition, making it fun and patient focused wherever possible. Engagement by providers is crucial, creating champions, leveraging stakeholders. We work a lot with our GI service lines, and then external partners that I mentioned, like the American Cancer Society, Washington Health Alliance, Exact Sciences, et cetera. And then wherever possible, kind of creating some accountability for the work, to not only say, hey, this is important, but kind of be able to take that back to the clinic level and say, hey, how do we want to work on this? What do we want to improve? So that's been really helpful for us. Some future opportunities for us are continued marching towards that 80% screening goal, and doing more health equity work and looking at where we have gaps in kind of our overall equity approach. Some things we're focusing on right now. So thank you very much for the time. Appreciate it. And I think we're moving into Q&A if there's still time available.
Yeah, I think there is. And thank you so much. I mean, wow, all the information that you three have given us in the last few minutes. I know we're going to want to be going over the recording and reviewing the slide decks. I think I'm going to wait on the poll because we don't have a whole lot of time. And I would like to ask all of you, Catherine, Wendy, and Colin, a little bit more about the equity approaches that you might recommend. And I guess I would start with the Exact Sciences team and ask you kind of how you would recommend that purchasers potentially work with payers on this sort of the equity aspect, or any other advice that you have.
Well, I'll go first and then I'll defer to Wendy, but I know at Exact Sciences, there are actually two kind of teams. One is the medical affairs team where I am, and my team provides a lot of unbranded education. So I think the first part would be, and Wendy's on that team too, is to educate payers about the problem and what the solutions are and what options are. And then we have our commercial team, which is really wonderful, that can talk about specific products. And within that team, there are lots of options. There can be individual ordering, there can be bulk ordering, there can be different programs set up with payers. So they have a breadth of knowledge and lots of different options to provide to patients.
Yep. And let me just add to that, just a shout out to, we also have our own internal health equity team, and that's dedicated to understanding health equity issues. And so that can also be presented at an above brand level. And so that just shows the dedication Exact Sciences has in looking at this from multiple angles. And so we can look at it from an economic angle, we can look at it from a health equity, social determinants of health angle. So there are multiple facets that we can potentially help everyone with.
So, same question, really, Colin. I know from working in various health systems that, the availability and potential accuracy of any race, ethnicity, language data is not probably as complete as we wish it would be. What are the ways in which Virginia Mason Franciscan Health is approaching health equity to kind of address those issues that Catherine spoke of, with the racial disparities, and also, what we've learned about socioeconomic challenge?
Yeah, sure. I mean, I think first and foremost is just we've definitely set it as a priority for an organization, right? So having that organizational initiative that this is important and to focus on it's been really helpful. I think data is really helpful and important. So like you said, there is lack of accuracy in the data, but starting to kind of look at it more from SDOH, social determinants of health, or driver's lens has been very helpful for us. So we're in the earlier stages of implementing more robust questionnaires to patients about social determinants of health factors. So once we kind of have that data, lining it up to every metric and being able to identify really your kind of pockets of opportunity will kind of be our next stages. We're still kind of in the early stages of that, but you know, case study groups or patient groups to get input from patients is something we focus a lot on. Creating educational materials and creating you know, ideas around barriers and how do we address those barriers.
Definitely multifactorial. I have more questions just about the equity, but go ahead. Sorry.
Sure. No, Jimmy, let me just add to that, also Exact Sciences has a wealth of researchers, scientists. So we're more than happy to collaborate with external folks to address a particular question in mind, especially as it relates to health equity and social determinants of health.
And we also, oh, I'm sorry. We also have a built-in navigation system. So that includes education and directions in lots of languages. We also are looking at health literacy, so creating a picture type of pamphlets and meeting patients where they are. So that is the important thing, is getting that screening done and being able to meet the patient where they're at.
And just kind of, you know, wondering about some of the other issues that may be barriers for certain patients, such as potentially areas where purchasers could interact. Again, I'm going back to purchasers interacting with the payers, so the health plans. We notice in our data, for example, when you get out to those higher deciles of economic disadvantage, it looks to us very much like, well, the total cost of care go up for those patients, and it's more intense care, such as hospital service, ER, hospital outpatient. And we're wondering if benefit design is keeping people that have, for instance, high deductible health plans from availing themselves of certain services. Now, we know that preventive care is supposed to be free of charge, but I know somebody has to pay for it. And how do we make sure that this kind of actual fiscal cost isn't a barrier, and how can purchasers support that at all?
Well, I'll kind of chime in on that. I know that March is National CRC Month. We are, again, available at any time of the year, but it would be nice for organizations to put out on their intranet information about the various awareness months and to provide links to information. We have lots of information that can be branded towards your organization that will provide education to individuals so that they can get screened earlier and bring those costs down.
Sure, I think I have. Sorry.
Sorry, I think I have two parts to this. So first is leaning back to what Catherine mentioned with the shared decision-making process, that make no assumptions, just try, hopefully patients and providers do not make assumptions about each other, and that they have to have an open and transparent conversation, especially with potential associated costs, because we know not all plans will cover the same treatment options equally. And so I'll leave it at that. And the second one addresses really just understanding again the patient journey and taking into account the patient wishes. And so without forcing them or without blaming a plan or blaming anything, I think, you know, going again, just hammering in on shared decision-making process, that I think that's really critical, and being able to understand barriers and how to appropriately address them.
Thank you so much. Well, we are right there at the bottom of our hour, so we are not going to go forth with our polling. It's fine. But I really want to thank you, Catherine and Wendy and Colin, for the wonderful material that you shared. Again, this will all be shared out with you. We at the Alliance would be more than happy to entertain. If you have follow-up questions, we will see if there was anything in the Q&A that we can answer. And I hope this was worth your time today. It was really a pleasure bringing this to you. So thank you so much, everyone.
Thanks for having me. Appreciate it.
Thank you.